Dr. Ziad Zahrani is Senior Consultant of Internal Medicine and Rheumatology in King Abdulaziz Medical City in Jeddah, Director of Rheumatology Training Program and Director of Military Medical Committee. He had a Master of Medical Education and Diploma in Epidemiology and Biostatistics. Dr. Ziad, you are welcome.
Thanks, Dr. Mansour. Thanks. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. It's my pleasure to be with you today, and my talk is going to be, where's the pointer? I thought I would... All right, can we get the slides on, please, here? Because where's the slide? Project the slides. So بعدين كيف نتحركها مشكلة. أي أعطيتهم. خليهم. Preoperative assessment for rheumatic diseases, and hopefully I'm waiting for projecting the slides. So this is, I believe, is a very important topic when we deal with patients with rheumatic manifestations and who are going to go for surgical interventions, and specifically when we talk about our arthroplasties. So let's get the slides on here. السبيكر عندهم اعطيته من اول انت دي معك. All right. So right, so the talk that I'm going to talk about it, as I told you, is the perioperative management of patients with rheumatic diseases, and here are the objectives that we'd like to go over today. I think the important topics, as you can see, is to identify the trends in the arthroplasties actually over time in those patients who are going for surgeries, including the non-inflammatory and the inflammatory arthritis. Then we'll talk about outline the important history and the physical points that are related to the perioperative management. And then we will try to describe the investigation and the approach for that aspect needed before the surgical interventions. And eventually we will try to present the perioperative management related to medications according to the recent guidelines and the list factors responsible for perioperative infections. And I think Dr. Nizar already mentioned some important aspects related to this. Now, as an introductory aspect for the perioperative assessment, which is a very important topic, as you know, the rates of orthopedic surgery use among patients with rheumatic disease remain high despite the number of developments in the field with a lot of introduction of biologic therapies. Now, the patient with rheumatic disease are complex surgical candidates because of their disease. We know that patients who have active disease like rheumatoid arthritis or SLE, they are prone to develop infection risk. And so not only the disease itself, but also the immunosuppressant that are used as part of the treatment for those patients are putting them at increased risk for the infection. Now, existing systemic manifestations of the rheumatic diseases must be identified and carefully evaluated and assessed before the patient goes for surgery. And the goal of the perioperative management, in fact, is to balance the risks of the infection and the disease flare. Major orthopedic surgeries such as the total joint arthroplasties actually continue to be highly used procedures among patients with rheumatic disease. And despite the advancement, as we mentioned, in the therapies, the rate of large joint arthroplasties for patients with rheumatoid arthritis has remained high over time. The complications are also higher in those patients than for patients with osteoarthritis, for example. And that basically puts an important aspect related to the disease itself. Now, complications, as you know, include infections and hip dislocations, venous thromboembolism, and dehiscence of the wounds, and acute kidney injuries and cardiac complications. So these things has to be taken into considerations. Now, just to give you an idea about the trends of arthroplasties in the U.S. population, for example, between 1991 and 2005, there was about 3 million arthroplasties that were done during that period of time. And the knees, the hips, and the shoulders are the major joints replaced. If you look into this kind of analysis, almost 97% of those surgeries are done in those patients with non-inflammatory arthritis. So that basically makes the bulk of the surgical interventions. Only about 3% are related to inflammatory arthritis, which is something really good because I think we are trying to decrease the risk related to these procedures. Now, let's look into, for example, the difference between the rates in 1991 and 2005 in terms of the figures related to the arthroplasties. And you could see, for example, in the non-inflammatory arthritis, there was about 124 cases done per 100 patients a year. So in 2005, actually, there is almost doubling or even more for the inflammatory arthritis. But look for the non-inflammatory arthritis, meaning, for example, osteoarthritis or others. Now, for inflammatory arthritis, you would notice that the rate remained the same, 5.1 per 100,000 in 1991 to almost, it's not moving, slides. Oh, sorry. I think I'm just looking. All right. So as you can see here, these are the figures that I'm talking to you about, where you see that the non-inflammatory arthritis is actually having the bulk of the surgical interventions done over time in comparison to the inflammatory arthritis, where the interventions remained stable. For example, the cases of rheumatoid arthritis here, you're talking about 4.6 cases per 100,000. In 2005, it's almost the same, 4.5. But look for juvenile idiopathic arthritis, and here we see that there is a reduction actually in the number of the cases done from 0.22 to 0.13. So there is a significant drop actually in the interventions in the juvenile idiopathic arthritis. And in spondyloarthritis, there is a little bit of an increase, and even actually the age of the intervention for those patients was even higher. Now, this is graph actually is showing you the difference between the non-inflammatory arthritis and the inflammatory arthritis intervention rate. And you can see basically the bottom black line represents those cases where they have inflammatory arthritis, and it's stable over time, where there's an increase actually of interventions in the setting of non-inflammatory arthritis. Now let's see here again the surgical interventions. What are the joints that are most commonly replaced? And you could notice that the highest number is for the knees, the hips, and then the shoulders. And certainly the knees are really increasing in terms of the numbers that were done over the year. And for example, in 91, almost 49 cases per 100,000. It's getting almost 134 over 100,000. And the inflammatory arthritis, for example, they are more or less similar. For example, for the knee in inflammatory arthritis, we're talking about 2.7 per 100,000, which is almost 2.8 in 2005. So the rates are stable over time. Now, those actually data in the US were a little bit probably before the introduction of the biologics. And so now when the biologics were introduced, actually starting from 98, and there is actually a widespread use now of the biologics in the treatment of rheumatic diseases. This is a study from, for example, from Spain, showing you the trends in the arthroplasties over time. You could notice that, for example, in 2000 to 2010, we are seeing, for example, a drop, significant drop in the number of surgical interventions or arthroplasties from 25% in 2000 dropping to almost 7.4% in 2010. And this is probably a good thing that's reflecting the efficacy of the treatment that we are utilizing. So now let's focus here about the history and the physical examinations. When we see patients in the clinics and there are actually an indication to do an arthroplasty, we need to evaluate those patients before they go for surgery and to clear them for surgery. So here there are important points that you always want to have, and you need to know about the patient's age, of course, because the patients who are older, they are more likely to have problems with arthroplasties. The indications for the surgery and the duration of the disease are important aspects whenever we think about replacing joints. The current functional level and the disease activity. Always we want to make sure that the patient is having the best time before the surgery, because this is an elective surgery. This is not an urgent surgery that has to be done overnight. I mean, we need to make sure that the patient is in the best time for going into surgery, because first of all, we need to make sure that their disease is at least inactive or the lowest possible disease activity, because we know the risks of complication increases if the patient is having higher disease activity. And this goes for rheumatoid arthritis, systemic lupus, and what have you. A specific joints involved also plays an important role in terms of the risk for complications. Presence of extra-articular manifestations, like, for example, the patient is having an interstitial lung disease, or the patient is having a comorbidities like coronary artery disease or others. These are diabetes, for example. These are all important aspects that you need to take care of and need to have it also to treated and in the best situation. If the patient had previous surgery, did he run into complications before due to the anesthesia, to the surgery itself? So these are important points that you need to take care of. Now, what about the physical points that you need to also assess, including the importance of the body mass index? Those patients are obese. They are prone to develop complications in the form of even, for example, deep vein thrombosis, pulmonary embolisms, and others. Cardiovascular assessment is important actually in this particular situations, and we need always to examine the heart for evidence of murmurs or third or fourth heart sounds. And if this patient has any of these features, definitely he needs further assessment, including probably echocardiography and cardiologic assessment. Respiratory assessment, also important to look for evidence of crackles. If this patient is having interstitial lung disease, then probably he needs further assessment by BFTs and HRCT and others. We have already stressed the importance of the assessment of the disease activity, and always we want to make sure that the patient is in the best state. If the patient is having active disease, we can cancel the surgery. There is no need actually to do it in this setting, because that you are going to increase the risk for this patient. We have to make sure that he is at least in the lowest possible disease activity. We have also to make sure that the patient is not having any focus of infection. So the assessment of the skin, for example, is one of the things that you have to do when you are going to assist the patient for surgical interventions. Joint assessment, like for example the cervical spine, especially when they are going to go for intubation, this is important, and we have to assess it. And we have already talked about the skin integrity. Now look into these basically situations. For example, the first patient having extreme stasis in the lower limbs. If you're going to do a surgery in this patient, you are fighting for problems, because he may run into really an infected actually prosthetic joint, and that goes for forever. So it's better actually, even in this situation, not to do it. I mean, because really the first principle is no harm. And again, if the patient is having any wounds, because that's an entry for organisms, definitely you need to treat these things before you get to do the surgeries. If the patient is having an active psoriasis, skin psoriasis, which is near the joint, this is again an indication to cancel the surgery. You need actually to treat that, and we do have now good biologic that can clear these skin lesions over a short period of time. Usually in 3 months, the patient is in good state. So this is really important to make sure that the patient is not having any thing that can increase the risk of the patient's complications like infection. I mean, if you do it in a psoriatic plaque, which is having a lot of fissures, maybe a lot of colonized microorganisms, then this patient is going to have infection for sure if you are going to do the surgery through this affected skin. Certainly the investigations that are needed to be done include, of course, the CBC, because you'd like to make sure about the patient's hemoglobin status, about the cytopenias, and of course, renal and liver, profiles. Especially we know that a lot of patients are on traditional DMARDs like methotrexate, which can increase the risk of hepatotoxicities. Uric acid level may be a good idea to do it, because those patients, remember, you don't want to have a patient who's running into an acute gouty arthritis afterwards, and you don't know what is this possibility. Is it really gouty arthritis, infection? But if you have a uric acid level before, you know it's pretty high. This patient is at risk of getting, gouty arthritis. Of course, the coagulation profile, urinalysis and urine culture. Always make sure that the patient is not having asymptomatic bacteriuria, because that can lead to septicemia and then seeding the joint. So it needs to be treated before actually getting the patient to do the surgery. ECG, chest X-ray, these are all baseline investigation that needs to be done. And then, of course, we've talked about the cervical spine, especially in the setting of rheumatoid arthritis and ankylosing spondylitis. You need to do these, a lateral flexion and extension fuse in order to make sure that the patient is not having any atlantoaxial subluxation. So these are really important things. There are certainly specific problems in rheumatic disease related to certain diseases. For example, in rheumatoid arthritis, we always want to make sure about the cardiovascular risks. And this is really important. You have always, because those patients, they have probably decreased capacity for mobility. They may not have the clear, symptoms for coronary artery disease. So always you want to make sure about their risk, stratify the risk, like if they are diabetic, if they have hypercholesterolemia and others. Important before, putting the patient in the risk of getting myocardial infarctions after the surgery. Of course, some patient may need echocardiogram, as we've mentioned. Pulmonary assessment also is important. Make sure that the patient is not having an interstitial lung disease, and if so, you need to assess it properly. Cricoarytenoid arthritis is a problem if the patient is going to be intubated and if it's not really assessed before, because those patients may be asymptomatic. The only thing that might help you is the patient is having some hoarseness in the voice or some difficulty in inspirations that might lead you to think about it and to warn actually the anesthetist that they may run into problems if they injure the cricoarytenoid cartilage. Okay, just quick, that will be. Again, specific problems in rheumatic disease is the atlantoaxial subluxation, and we have already talked about it. Systemic lupus erythematosus certainly is another important disease that you need to talk about it, and especially the hip arthroplasty in patient with SLE is associated, in fact, with a higher risk for complications. Of course, the issue of the antiphospholipid syndrome, you have always to address it and make sure that you screen for it before you do these kind of surgeries. Now, this is just to give you a quick outline of the medication. What you're going to do about the medication the patient on before, when should you stop them? Now, this basically graph hopefully is going to show you quickly the importance of the ACR 2017 recommendations. And what you can see that patient with immune-mediated inflammatory diseases on biologics, first of all, if the patient is on a synthetic DMARD, there is now a good ample evidence that those medications like methotrexate and leflunomide and what have you are not associated with increased actually risk if you continue them throughout surgery. So that's okay to go ahead and continue these medications, including methotrexate, leflunomide, azathioprine, sulfasalazine, cyclosporin, and hydroxychloroquine, apremilast. These drugs can be continued, certainly. Now, what about the setting of, mycophenolate, mofetil in the setting, for example, lupus? We have to assess the disease activity of the lupus. If the patient, unfortunately, was having active disease and there's no way except to go ahead and do the surgery, then this particular patient, definitely you can go ahead and continue these therapies, including mycophenolate and others. But if the patient is having non-severe, SLE manifestations is stable, then this particular patient, you can stop it for about 1 week before the surgery, and you continue it 3 to 5 days afterwards. What about actually the tofacitinib? Tofacitinib, I think, can be actually stopped for about 1 week before the surgery, and then it can be continued once the wound healing has happened, usually about 14 days. You have to make sure that the patient is not having any features to suggest any wound infections. Now, what about the biologic DMARDs? We're talking about Enbrel, we're talking about, etanercept, adalimumab, and others. It's pretty simple here. But basically, what you do is you plan the surgery at the end of the dosing cycle. For example, etanercept is given every week, then we plan the surgery in the second week. Adalimumab every 2 weeks, we plan the surgery in the third week. Tocilizumab is given intravenously every 1 month, 4 weeks, then we make it in the 5th week, and so forth. So it's pretty simple. What about Rituximab? Again, it's given every 6 months, then we're going to do it in the 7th month. We plan the surgery at the end of the dosing cycle. So that's it. And when should we resume it? We usually resume it when the wound is healed, and usually that's about 14 days. And make sure that the sutures is taken and the patient is not having any features. And so always we want to communicate with the surgeons. Once they feel that the wound is okay, then they can, or if we do not manage to see them, then probably they can be instructed to resume their therapy. I think this is the same table from the ACR 2017 recommendations, and I think I've already talked about it. NSAIDs, I think definitely you can stop them 2 days. That's basically safe for all of these NSAIDs. Celecoxib does not have any platelet activity and can be continued if needed during the period of the perioperative assessment. Now, what about the medications related to steroids? In fact, if you look into the steroids, always we want to make sure that the patient is the lowest possible steroid, usually 5 milligrams to 10 milligrams. But if the patient was on higher dose above 15, definitely we do not want the patient to go for surgery while he's on that high dose. And so we need to make sure that we delay it until the patient is on a lower possible dose, which is less than 15 milligrams. However, in the ACR 2017, they mentioned that you just continue the patient on the usual dose of steroids. There's no need to do any stress dosing, because there is now ample evidence that there is no difference whether you give the stress dose or not. There's nothing. But definitely you need to follow the patient for the hypotensive episodes that can develop due to the adrenal insufficiency. So here, the factors that are responsible for increased risk, including basically the medications that we have already talked about it, comorbidities, surgeons, disease itself, and others. So these are all risk factors related to the infection. So here I come to the end of my talk, and just for the follow-up, I think you have always to make sure that the patient is not having DVT, no infection in the wound and others. So these are all important features to make about it. In conclusions, the history and the physical examinations are equally important. Identify the pre-existing abnormalities always. Correct the correctables always. And we said it again, and we're going to say it now, is that this is an elective surgery. Okay, so you have to make sure that this is the best time for the patient mentally and physically, and also the best time for the surgeon to do it. And the medications, be aware that daily medications may not be the only medications. You have always to ask about the biologics. Sometimes the patient may not be able to tell you about them. All right, so with this, I will finish my talk, and thanks a lot for bearing with me, and I thank you a lot. And sorry for the technical inconvenience that we had. Thanks.